Hi, welcome to the program, Migraine 360, translating a novel treatment paradigm for real-world clinical practice. So my name is Clay Jackson. I am an assistant professor of clinical psychiatry and family medicine at the University of Tennessee College of Medicine, and that's here in Memphis, Tennessee. And I'm delighted today to be joined by Dr. Steven Silberstein, who's professor of neurology, and he's the director of the Jefferson Headache Center, and that's at the Thomas Jefferson University in Philadelphia, Pennsylvania. So this program is provided by the North American Center for Continuing Medical Education, LSC, and that's an HMP company. And the program is supported by an educational grant from TIVA. Our learning objectives today, we're going to describe the evidence-based practices for the treatment of acute migraine, and we'll discuss some of the risk of mismanagement or suboptimal management. We'll review the pharmacodynamics of novel CGRP monoclonal antibodies in the role of migraine prevention, and small molecule CGRP receptor antagonists, and we'll talk about their latest safety and efficacy data. We'll also discuss factors for informing patient selection for migraine prophylactic treatment. So with that, let's take a look at this calcitonin gene-related peptide, or so-called CGRP, and we'll refer to it by its initialism throughout the program, CGRP. Basically, this is, you might consider it a membrane cellular messenger system that's involved in vasodilation and also inflammation or neurogenic inflammation in the brain. If we look at migraine pathophysiology, CGRP is intimately related with the pathophysiology of migraines and how they present in humans and also in lower mammals. CGRP receptors are involved in mediating vasodilation, and this contributes again to the neuroinflammation of which we were speaking. This has to do with how we perceive pain in the brain due to excessive vasodilation. When we look at the mechanisms of migraine peripheral pain and how we experience pain, again, vasodilation intimately associated with neurogenic inflammation. And so if you can see the cartoon in the upper left-hand corner, we see a serotonin receptor, and that is mediating, if you will, neuroinflammatory responses. There are neurokines, substance P, CGRP, and perhaps other inflammatory mediators that are released in response to a neurotransmitter signal coming from the serotonin 1 or 5-HT1 receptor. When we look at how the vasculature and the neurogenic inflammation is intimately related, we see that the small vessels that are invested with the neurons, actually, as the neurons send a signal for inflammation, the vessels vasodilate, and this creates a positive feedback cascade whereby vasodilation and neuroinflammation influence one another. And this leads to prostaglandins, kinins, and other inflammatory mediators that can cause perception of pain. I love the cartoon in the lower right that just sort of shows a blood vessel that is vasodilated, and then you see sort of a neuroinflammatory cloud of demonstration of inflammatory products surrounding the vasculature. If we look at data that supports the role of CGRP in patients with migraines in terms of how we build a pathophysiologic module, when we look at measurements of CGRP levels or concentrations in the external jugular vein, so this is basically the return from the brain, we see that during spontaneous migraine attacks, CGRP levels are quite high. If you look at patients who are migraineurs, if you infuse intravenously CGRP into their bloodstream, then they have attacks that are indistinguishable from de novo or natural migraines. After administration of triptan, CGRP serum levels decrease, and this is in parallel with the symptomatic relief that's seen in patients with migraines. And so we believe that the triptans actually function by lowering CGRP levels in part of the explanation of their efficacy. If we block or remove CGRP, this terminates the migraine acutely and prevents migraines in patients who are predisposed to migraine activity. If we look at migraine treatment, and CGRP is sort of at the center of our management model in terms of pathophysiology and the pharmacology, let's take a look at how some of our different agents may act. Well, triptans and argots, they prevent CGRP release, and they constrict CGRP dilated vessels. And this is by acting basically at the 5-HT1B or 5-HT1D receptor. Again, this is the serotonin 1 receptor on the surface of the trigeminal nerve. We also have onabotulinum toxin A, and this prevents CGRP release from the trigeminal nerve. And so this explains the efficacy of that treatment group. In terms of CGRP antagonists of the so-called Gepants, this is Ubrogepant, Rimegepant, Atogepant, and Vasogepant. These agents, they actually are antagonists at the CGRP receptor. And then we have monoclonal antibodies that also bind the receptor, and we have one of those, Erenumab, and this Erenumab binds to the receptor and prevents its second messenger activity. And then we also have some of the smaller anti-CGRP ligands, and these actually bind as antibodies to CGRP and prevent it actually from activating the CGRP receptor on the cell surface. Well, if we look at episodic migraines, what's sort of the natural history and how might this develop into chronic migraine? This is a study called the Cameo study. And what you see is that there's sort of a wave of headache activity and monthly frequency from very few headache days to very many headache days. And this is part of the natural history of migraines in patients. If we look at episodic migraines, which we just saw, that sort of biphasic wave, what is the frequency to medication overuse or to chronic migraine? It looks like basically, if you look at episodic migraine patients, those that are in that roller coaster wave of frequency, it's about 2.5% of those that progress annually to chronic migraine. And if you look at low, high frequency migraines, less than 10 or 10 to 14 days of pain per month, going to chronic migraine, which is more than half the days or half the days being associated with migraine, again, it's about 2.5%. But over a year, you see that 56% of patients move to episodic migraine. Over 2 years, 66% of them do as well. So we want to prevent patients who have episodic migraine from progressing to chronic migraine. What are some of the predictors of development of chronic migraine in patients who have EM or episodic migraine? Well, we see that there are a number of those: Caucasian race, lower education, previous marriage, obesity, other diseases of inflammation such as diabetes or asthma, using a lot of caffeine. I have to raise my hand on that one. Stressful life events, so the psychosocial milieu can be contributory. Head injuries such as chronic traumatic brain injury, snoring or other sleep disturbances or sleep apnea. But the ones that are most important include a high baseline frequency of headache, medication overuse, and then inadequate or incomplete acute treatment. This sort of should ring off alarm bells in our heads as practitioners that if we don't get patients' headaches under control in the acute setting, they may progress to chronic migraines. Again, frequency of headaches at baseline, frequency of acute medication use, and the higher the likelihood to progression of chronic migraine, especially if their acute treatment is inappropriate or suboptimal and they don't get adequate relief. So what are our goals in terms of optimal acute treatment? Well, we'd love to say that if the patient had a headache, it's one and done. There's sustained pain-free response, but the poor acute treatment is associated with chronic migraine risk. Take a look at this study. Nearly 6,000 patients who had episodic migraine. This is from about 15 years ago. There were 3.1 of them that 3.1% who progressed to chronic migraine. So again, remember we said about 2.5% annual progression from episodic migraine to chronic migraine. This is commensurate with the findings of this very large study. But if you looked at those who had maximum acute treatment efficacy, only 1.9% of those developed chronic migraine. So there was a significant relative risk reduction of progression from episodic to chronic migraine. And if you looked at those who did progress, those who had poor treatment efficacy and had suboptimal acute treatment efficacy progressed at a much higher rate. So if you have very poor acute treatment efficacy, it was more than 2 times the risk relatively of progressing to to chronic migraine. So again, our conclusion from this study is that inadequate acute treatment efficacy is associated with increased risk of new onset of chronic migraine over the course of a year. But if we could have optimal acute treatment, we might be able to prevent this progression to chronic migraine. And with that, Stephen, I'm going to turn the talk over to you for discussion of some exciting newer treatment modalities that we may use, hopefully to be efficacious in treating patients with acute migraines, in preventing migraines, and preventing those patients from progressing to medication overuse and chronic migraine.
Hi, this is Dr. Stephen Silverstein, and I'm going to pick up the program at this point in time. First, I'm going to talk about the DIT-10, lasmiditan, for the acute treatment of migraine. Well, you heard earlier about the role of serotonin in migraine pathophysiology. The triptans were drugs that work at serotonin receptors. They work at the B receptor for blood vessel, the D receptor, and the F receptor. And the major problem we had with them is that the triptans acted as vasoconstrictors. So a new class of compounds was made. It eliminated the B and the D receptors and maintained the F receptor. This is the DIT-10, and it works to stimulate the 1F receptor and inhibit CGRP release. It also has central action. Because it doesn't have the B receptor, it doesn't constrict blood vessels, and the 2-hour pain freedom rates are approximately 30% compared to placebo 15. Important to realize that with the use of this drug, because of its central penetrance, some patients develop dizziness or somnolence, and they've been advised not to drive or operate a machinery for 8 hours after dosing, even in the absence of side effects. And it's considered a controlled substance class 5, same as pregabalin. The next class of drugs are something you heard about briefly before, are the Gepants for the acute treatment of migraine. Basically, these are small molecule drugs that antagonize the CGRP receptor. You've had 7, the early ones had some side effects with liver toxicity and were discontinued, but since then new Gepants have been developed that do not seem to have that problem. We have Ubrogepant, Rimegepant. It looks like about 20% of the patients get pain freedom at 2 hours, and there are other drugs that are currently being developed, nasal formulations, and also for prevention. If we look at some of the data, the Achieve 1 and the Achieve 2 data for Rimegepant, you can see the placebo response rate, and it's about 12%, and the drug worked about 20% of the time, which was statistically significant. If you look at Rimegepant in the phase 3 trials, the freedom from pain, again, 20% and 10%. And the other thing we're looking at now in migraine trials is freedom from the most bothersome symptom. What does that mean? Patient says, I have a migraine attack. Light hurts me more than anything else. And then they see at the end of the trial it's gone. That's called the most bothersome symptom. And surprisingly, it's really light sensitivity in most patients more than nausea. So you look at the safety and tolerability. Actually, if you look at these drugs, they're very similar to placebo. The issue, because of the prior drugs in this class had liver toxicity associated with them, this was very carefully looked at. And basically speaking, it looks like there was absolutely no evidence of liver toxicity from these drugs. If you look at the adverse event profiles, you can see that there's liver function abnormalities, and basically there was as many in the placebo that there were in the active drug, suggesting that these were events not related to the treatment. The adverse events in these are no different, or very close to placebo. Now, who should get these treatments? They should be available by a licensed healthcare provider, and the patient should have a contraindication to a triptan, of lack of tolerability, perhaps also an additional lack of adequate response, and you need to be able to justify and determine that the patients need the drug. And basically, you need to treat with the older medicines released to attacks to evaluate how safe they are, how tolerable they are, whether or not they're effective. Now let's look at the migraine preventative treatment landscape before 2018. One of the interesting things we found out is if you look at people who are started on a preventative drug, after 6 months, only about 30% are on it. If you go to a year, it's only about 17%. Why? The big two reasons for discontinuing the drugs are doesn't work or side effects. Now let's look at the Gepant's potential for migraine prevention. In a long-term safety study, patients taking Rimegepant noticed a decrease in the number of migraine days. Again, this is open label and it doesn't prove anything, but it strongly suggests it. So, preventative use. Calcitonin was studied in the past, but the studies were terminated because of hepatotoxicity. And for Atogepant, Rimegepant, the current trials are underway. Let's look at the phase 2 randomized controlled trial for episodic migraine prevention with Atogepant. And the easiest way to look at this is the fact compared to placebo. And if you look at the days that are decreased, about 4 days. 4 days. And if you compare it to placebo, you can see the statistically significant difference between the active drug and the placebo, showing it was effective. Let's next move to monoclonal antibodies. Well, the question arose, since we knew that the Gepants that were originally made were toxic, people took a different approach. And they wanted to use monoclonal antibodies, which are large molecules that do not pass into the brain. And since they're metabolized by the reticuloendothelial system, there's no liver toxicity. And they really work peripherally to prevent migraine. The picture you see there, Chenju, she is the one that developed the first monoclonal antibody against migraine. And basically, if you look at the size comparison, MAB is like a truck where Gepant is like a grain of rice. So they're big molecules. And at this point in time, there are 4 monoclonal antibodies available in the United States for the preventative treatment of migraine and 1 for cluster. Erenumab, Rimegepant, Calcitonin, Neptinzumab. So what are the fundamental differences? Erenumab is the only monoclonal antibody directed against the CGRP receptor. The other 3 are directed against CGRP itself and prevent it from going to the receptor. If you look at the injection paradigms, Erenumab and Calcitonin are monthly. Preventive is monthly or every 3 months, and Neptinzumab is every 3 months. Now they're all approved in the United States. But in addition, for migraine and chronic migraine, both episodic chronic, Calcitonin has now been FDA approved for the treatment of episodic cluster headache. So let's look at them. Erenumab, Calcitonin, Preventive, Neptinzumab, and basically speaking, in one case it goes to the receptor, in the other case, the other 3 drugs go to CGRP itself and prevent it from going to the receptor. As I mentioned earlier, that Erenumab, Rimegepant, Calcitonin, they're monthly. In addition, Rimegepant is can be given every 3 months subcutaneously. Neptinzumab is intravenously given every 3 months. Now let's go back a little bit. What's an antibody? It's a glycoprotein. That means a combination of a protein with sugar groups on it. It has 4 polypeptide chains, 2 identical heavy chains and 2 identical light chains. It forms a classic Y-shaped structure. The L chains are bound to the heavy chains, and the H chains are linked by hinge regions. This is an antibody. Now, what's the difference between a polyclonal versus a monoclonal antibody? A polyclonal antibody is what we all have. We get a bacterial infection, we develop antibodies against it, and there are different sites in the bacteria create formation of antibodies. They're made from multiple B cells, and it recognizes something called an epitope. That's the part of the thing that the antibody attacks. In contrast, a monoclonal antibody is from a single B cell, and it recognizes one antigen epitope, one specific site on the antigen itself. How do antibodies work? Well, for example, with the antibodies for CGRP, they can neutralize the soluble CGRP or go to the receptor. Indirectly, they can actually target an immune cell and make it attack another cell, or actually destroy the membranes itself, working with something called complement. What's the difference between a small molecule versus an antibody other than size? Small molecules can often be given orally. The antibodies need to be injected. The small molecules may enter cells and cross the blood-brain barrier. The antibodies do not. The small molecules last hours to days. The antibodies can last months. Small molecules are made chemically, and the large molecules, antibodies, are made in tissue culture. Just as an aside, the exception to the rule is there's one time in life when you can actually ingest antibodies, and that's in the period right after birth when the infant gets most of its antibodies through the mother's milk. After a month or two, that ability goes away. So here's the 3 questions we want to ask about antibodies. Are they safe? Are they different? Are they an improvement? Safety. We mentioned before, we have 4 different monoclonal antibodies. The major problems we've had with all of them that are injected are injection site reactions. And several of them we've noticed constipation, mainly Erenumab in the United States. There's no liver problems. And the other thing that's recently been noticed and just changed in the label of Erenumab is some patients rarely develop increased blood pressure. So, one very interesting study, patients with stable angina were given either placebo or Erenumab, and looking what it did to their angina. They were put in a treadmill. There was no change in baseline in their exercise duration, no change in ST segment depression, and the time of onset to exercise-induced angina, no difference. So basically, in this model, there is no evidence that Erenumab aggravated pre-existing stable angina. What about the endpoints in the clinical trials? These are basically the 4 trials: Erenumab, Frimazumab, Galcanezumab, and Etinzumab. And as you can see, they all separate from placebo. Both doses work. They're all statistically significant. So we have 4 monoclonal antibodies. Each have been shown in placebo-controlled, double-blind trials to be effective. One of the interesting things were how quickly do they work? And if you look at all of the trials, they work quickly. Frimazumab, Galcanezumab, Erenumab, they all work quickly. And as soon as you start measuring it, they work. Remember, when you give an antibody IV, it's in the body immediately. When you give it subcutaneously, it peaks in a week, but it starts to work before that. So these are very quick working drugs. So are they an improvement in what we have now? 41 to 54% had a greater than 75% drop in the number of monthly migraine days by 1 year. Very high responder rate. We haven't seen that before. So to reiterate, one way I look at it is the following. If over half of the patients will get a 50% reduction at the primary endpoint, and of those, over half will get a 75% reduction. The longer you're on it, the better you are. What about the secondary endpoints? Does it work if something else is going on, comorbid illness? And what about patient-reported outcomes, disability, impact, and satisfaction? Onset of effect. Early onset, unprecedented. I showed you this a little bit earlier, Etinzumab, Erenumab, chronic migraine. As soon as you measure within a week, you are seeing things. And Etinzumab is faster because it's intravenous. So they all work very quickly, and the rate of onset of speed is when they reach therapeutic levels in the bloodstream. Now, one of the big questions we always ask is, Doesn't MAB work in those who didn't respond? In the past, in multiple trials, we always eliminated people who failed multiple drugs, and I think it was a big mistake. Let me show you why. If we look at the Erenumab and the Rimegepant trial, and these are patients who failed multiple previous events, the major effect of having multiple previous failures is you lower the placebo response rate. So therefore, if you look at the difference between active drug and placebo, it's greater. So basically, you improve what we call the therapeutic gain, and it makes it easier in clinical trials to tell the difference between active drug and placebo. So these antibodies are effective and approved for all migraine, episodic and chronic, with or without aura, and with or without medication overuse. They reduce acute migraine medication use and episodic migraine, reducing the risk in chronic migraine and medication overuse headache. They convert patients back to episodic migraine and out of MOH. Examples: in those using acute medicines more than 10 days a month, Atogepant reduced acute dose by 50%. In Preventive trials, 813 patients with chronic migraine at baseline, 548 reverted to chronic migraine to episodic migraine, and the Erenumab trial, 72% of those completing the extension trial converted from chronic migraine to episodic migraine. And the Calcitonin trial, chronic migraine, again, acute medication use plummeted. So one of the questions to think about is, what do you do with patients who are overusing acute medicine? And we used to always say in the past, detox and then treat. I think we're now getting to the point we say treat and then many patients detox themselves. So this is really the 50% of the patients converted from a medication overuse to non-medication overuse in the Erenumab trial. And if you look at simple analgesics, triptans, and combination therapy, all of these drugs showed that the patients, despite never being told to stop it, a medication overuse decreased. So what do we look at it? Oxygen, fire, or CGRP, migraine. We actually deprive migraine of CGRP. It should not matter if the fire is wood, coal, or paper, the fire will be extinguished. Episodic migraine, chronic migraine, migraine with or without aura, or with or without medication overuse, it appears to work for all of them equally well. Now, how do we evaluate whether the MABs are superior to previous migraine preventative medicines? There are a number of things we can look at. The therapeutic gain, as I think I briefly mentioned, is you look for the active response minus the placebo response. So for example, if half the patients respond in a quarter to a drug and a quarter to placebo, then the therapeutic gain is 25%. Number needed to treat, it's the reciprocal of the therapeutic gain. For number needed to treat, the lower the better. For therapeutic harm, look at the adverse events between active and placebo. The number needed to harm is equal to the reciprocal of that. For number needed to harm, the higher the value, the better. For number needed to treat, the lower the better. The ratio is likelihood of being helped or harmed. Some people look at that as a risk-benefit ratio. They do not take into account the nature of the harm. So if you look at chronic migraine and episodic migraine, for chronic migraine, number needed to treat for the antibodies is about 6. To pyramid either 13 or 4, Botox is about 9. Similar for episodic. Number needed to harm is much higher with the antibodies than with the other drugs. Now, this really tells you that the fact that these drugs are as effective as the older drugs, and the ones that have the lowest number needed to harm are Erenumab and the antibodies. But again, it depends on what you mean by the number needed to harm. For example, if weight loss is a benefit, it could be considered a side effect. So you have to take that into account. So when should patients receive the new treatments? They should be available to be prescribed by a physician who, one, If they have low frequency episodic migraine, that's 4 to 7 headache days a month, two things should happen. You should have failed 2 prior drugs, but demonstrate disability or impact by the migraines. If you have high frequency episodic migraine, 8 to 14 attacks days per month, you don't need to have a disability proven, since by definition you're disabled. If you have chronic migraine, which is 15 or more days a month, same as one in terms of prior drugs or failure of Botox, and you do not need to document disability, as they clearly impact everybody. How are they given? Erenumab, Galcanezumab are self-injected monthly. Rimegepant can be self-injected and now has a new auto-injector to be given monthly or every 3 monthly. And Deptinzumab is given every 3 months by intravenous infusion. So you have 2 different devices to administer it subcutaneously, and one of the medications can only be given intravenously. So what can we conclude? The best acute treatment of migraine optimizes the likelihood of sustained pain relief and the likelihood of transformation from episodic to chronic migraine. CGRP is pivotal to migraine pathophysiology, and our research links CGRP to multiple anti-migraine treatments, including triptans, lasmiditan, Botox, Gepants, and monoclonal antibodies. And our statement in January of 2019 provides guidance for the selection of patients for the new acute and preventative treatments. Thank you, and I'm going to go to my colleague, and he will talk about the cases.
So our first case is Daisy. She's a 43-year-old Asian female. She has had 3 pregnancies. She has 3 living children. She's currently on orthotricycline for contraception. Works as a bank manager, and she's had migraine headaches for 5 years. But unfortunately, of late, it's been increasing in both frequency and severity, despite some treatment with triptans and PRN NSAIDs, or non-steroidal anti-inflammatory drugs. Right now, she's having 4 to 6 headache days per month, and she's been missing 3 to 4 days of work per month because the headaches, when she has them, are severe enough to, most of the time, to prevent her from being able to work. Her PCP had tried propranolol for maintenance. This didn't really work that well for her, and also she complained of feeling sluggish or tired with some fatigue with her propranolol. She also tried amitriptyline. It did help some, but she gained 8 pounds of weight, and she was very unhappy about the weight gain. And she wants to know if a new class of migraine agents might be appropriate for her headache prevention. So, Stephen, a few thoughts about this case and where you see this patient. Is this similar to some of the patients that you see, or do you see folks that are further down the line, and what are your initial thoughts about how we might help this lady?
Okay, this is the patient who's failed 2 prior migraine preventive medications,
Okay.
and clearly has evidence of disability because she's missed a lot of work and could
Sure.
potentially lose her job. So she clearly would be a candidate for the new medicines. Now, one of the points I want to make, which it's not on the label, but since this is the CME program, I can talk about it, is if you have a patient on a migraine preventative drug and they're doing fairly, I tend to add an antibody to it, and then if they get a good response, stop it. Because I think that many of these drugs are synergistic with the old medicine. That's the first point. And then the only other issue in this woman is that she had gained weight. So you might, while you're waiting to get permission, it might take a time to get insurance permission to get the antibody. You might put her a little bit of generic topiramate while you're waiting. And then I would try to get her the antibody. At least you're doing something in the meantime.
Absolutely. And I think the topiramate suggestion is a great one. And sometimes we can take advantage of a side effect or so-called adverse event. The appetite decrease with topiramate or the weight loss might be efficacious for her. And as you said, while you're waiting on prior authorization from a third-party payer, might be a decent strategy in this lady. So Dr. Silverstein, in our second case, we have Robert. He's a 27-year-old Caucasian guy. He works in construction as a framer. He's complained of daily headaches, which worsened when he began using a pneumatic nail gun in his work 2 years ago. He has 3 or 4 headaches a month, though, that are different. These daily headaches were worsened when he started using the pneumatic device. It's a pretty loud nail gun. But then these other headaches that occur 3 to 4 times a month, they're different, and they have scotomata, they have photophobia, and they're associated also with nausea. He takes a generic NSAID over the counter to help the daily headaches, and it does help them, but it doesn't help these intermittent headaches that he had, which he describes as being distinctly different. He says nothing has helped them but a combination product of etalbutol, caffeine, aspirin, and he's been taking actually about 60 of these a month. And so if you think about it, he's got sort of 3 to 4 headaches, and he uses NSAIDs for those, but he uses a combination product up to 10 to 20 pills when he has one of these intermittent different headaches. In the past, his PCP had tried nifedipine and topiramate. These were not efficacious. And he presents today and just says, all I need is a refill of the combination product because, I'm okay with using that. So do you have thoughts about this case? Are there a number of patients which present with sort of a more complex history where they may have 2 different types of headaches going on? How would you sort that out with this gentleman? And then what are your feelings about the continuation of this combination product with caffeine in it versus doing a different type, maybe a preventive medication or rescue for Robert?
Here's what I think. This guy has chronic migraine. The reason that the little headaches don't have all migraine features is, one, if he kept a diary, they probably would, but he's also taking a lot of medicines. And when they break through, they get more migraine features. 2, he's got medication overuse headache. So what you really need to do is tell him that the medicine he's taking in part is making his headaches worse. And what I do not do is say stop it and come back like they do in Europe.
Okay.
I would treat this guy with a preventative medicine that's effective, and we've shown for the antibodies, for example, that they're effective in helping people eliminate medication overuse headache.
Okay.
So I would start him with an antibody. I would educate him, and he's the type of person I might teach yoga to, or Pilates, self-control, or even biofeedback, and help him deal with the pain without having to treat it. And if after a month or 2, and he's on the antibody, he's not starting to improve, I might develop a systematic approach to withdrawal, including giving him phenobarbital, because people who take that much etalbutol, if you cold turkey, it could get a seizure.
Right.
And the other things I do are short courses of corticosteroids we could use to help break it, or even triptans, which he's not been using, can be used to break it. So you give him a tray. You don't say stop. You say we'll work on it, and you give him some medicines to help him.
So the general principles for Robert would be that you want to reduce the use of rescue medicine, treat this as chronic migraine using an antibody, but then in terms of sort of detoxing, if you will, from the medication overuse, you want to do that gradually by adding in a preventive medicine and then gradually taking things away and be sensitive to etalbutol withdrawal if he's using that.
Absolutely.
Okay.
And we've actually shown that patients do as well, if not better, by prevention first, detox later, as opposed to detox first, prevent later. It's much more humane.
I think that's an important point, because in primary care, I think we're probably more open to what might be called polypharmacy, or in primary care we call it multimodal therapy, because polypharmacy has a negative connotation.
I actually call it synergistic co-therapy.
Okay, yeah. And so put it on board and then wean down the things, rather than trying to get them in a pristine neurologic environment and then adding in a therapy.
Exactly. Can't do that to human beings.
They'll
leave you.
Wise. I also love the emphasis on non-pharmacologic therapy, because I think from an integrative standpoint, sometimes we view complementary or alternative therapies as being an either or, but they're both and, aren't they? We can use good pharmacology with good non-pharm interventions to help this gentleman have more of an internal locus of control and seize back control of his symptomatic life.
You sound like my psychologist. We believe it's not one or the other, but they're synergistic, and studies have shown you do better when you have both than when you do one alone.
Fantastic.
The other thing I would worry about in somebody like this with that many headaches and that much overuse is freedom for depression.
Absolutely. Well, that's a good segue into our final case in which the comorbidities of headache phenomena with depressive phenomena may come to bear. So let's dive into that third case. So Stephen, here's a third case for us. This is a 32-year-old African-American female. She's had 2 pregnancies. She has 2 living children. And in fact, she's in the postpartum period. She gave birth 6 weeks ago. to her second child. She's having intermittent headaches with aura, photophobia, and phonophobia. This started sort of during the second trimester. Her obstetrician did screen for papilledema and other pregnancy-associated problems that was not found. So she had no focal neurologic or ophthalmologic indications of increased intracranial pressure. Her obstetrician actually gave her hydrocodone acetaminophen, a combination product during pregnancy, because she was concerned about other medications and perhaps their in utero effect on the developing fetus. During the postpartum period, she also received sumatriptan, which has helped, but the headaches now are increasing in frequency. She took nortriptyline, then pregabalin without much effect on the headaches. She said maybe the nortriptyline helped a bit more than the pregabalin. Right now, though, she's reporting that she's having sleep deprivation and a decrease in mood. She said the infant is not sleeping well. Her husband works a second shift, and so he's not able to really help at nighttime. Her mother lives far away. She doesn't have other siblings close by to help. And so she's sort of alone with the child at night, and the child's not sleeping well, and therefore she's not sleeping well. She became tearful in the office at the initial visit, and she says, I'm really worried because I don't think I'm being a good mother. She has a couple of questions today. She wants to know if the sumatriptan is safe for the baby because she's breastfeeding, and if there are other agents which might be helpful for her. And so on the strength of her postpartum period and the expressed low mood and tearfulness, she was given a patient health questionnaire, PHQ-9 screen for depression, and that score was 13. If any of you are unfamiliar with the PHQ-9, a score of 13 would be consistent with moderate symptomatology during a major depressive episode. So moderate symptoms of depression on the screen in light of her findings. So a few thoughts from you, and I think our case brings up a number of interesting lines of inquiry. One of those would be, what's the role of hormonal perturbations around the peripartum period with respect to migraines? What's the role of depression with headaches in general and migraines specific? And then some of our therapeutic agents for migraine symptoms, what's their role in terms of breastfeeding and what we might expect? So with that, Stephen, what are your thoughts?
First of all, women during the third trimester who have migraine typically have significant reduction because of sustained high estrogen levels.
Sure.
Postpartum period, the levels crash, and it's very common to have migraine in the postpartum period. And some women have postpartum depression. So that's one fact. The second point is this woman is breastfeeding. So the major crucial issue is how much of a medicine that she takes is transmitted by breast milk. So for example, if she took sumatriptan, what we generally do is advise that the woman discard the next breastfeeding, because by that time it's out of the system. That's easy. Then in terms of antidepressants and other medicines, I would not give a monoclonal antibody to somebody who's breastfeeding because it is transported across the milk. That's the major source of antibodies for the baby. And we don't know what it means yet. So one, if this will, I would basically start, if she could afford it, with non-drug treatment. And I would include things such as biofeedback, yoga, cognitive behavioral therapy. A lot of things are now available online. Sure. The other thing is I would consider some of the devices. There are devices that work for acute treatment, which don't get in the body. And the third thing I might want to consider would be botulinum toxin and check their OBGYN, because generally it stays locally and there's little, if any, risk of being transported to the fetus. And then if these things continue, then, and she needs medicines in conjunction, I always look them up before I treat them. If she desperately needs an antidepressant, I would check my little Bible of antidepressants, which I wrote with one of my friends, since I don't remember everything, but I write it down. And if she needs it, then I would talk to her and her OB/GYN about it, and maybe she'd have to stop breastfeeding early.
Yeah, I agree with you that in general, we need to weigh the risks and the benefits of antidepressant treatment in this lady. Certainly the non-pharmacologic elements that you discussed, such as cognitive behavioral therapy, CBT, mindfulness-based cognitive therapy, such as MBCT, are certainly helpful, and zero side effects except the time that you spent to do it. And most people do note an improvement in wellness. With respect to pharmacology, we do use the SSRIs in the middle and third trimesters, and so there's in utero exposure, with respect to breastfeeding, yes, there is some transmission, but she's already self-expressed this thought that maybe she's not being a good mother, she's sleep deprived, and so we have to weigh in terms of the effects on the infant, a suboptimal mom who's just not functioning well versus how much is coming across in the breast milk. And I think that kind of analysis that's practical, involving the other specialists who might be involved with the health of the child is certainly important. But a depressed mother is not a highly functional mother, and so we certainly don't want to put blame on her or to endorse her picture of reduced self-efficacy. But we do want to acknowledge that if we can improve her sense of wellness and well-being, that will improve her baby's health, and that may overwhelm any small pharmacologic considerations that we have if the non-pharmacologic interventions are not worthwhile.
I agree. Risk-benefit ratio, you have to be careful. The other thing is there any data on the SNRIs being transported in the mother's milk?
So, we don't have clear data as we used to have in terms of studies, but the consensus around the psychiatric community is that, again, as we said, the risk to the infant through a depressed mom is much greater than the risk would come through a small amount that would come through breast milk. And as you said, sumatriptan, I think in this patient is a great agent to use because small amounts are transmitted through breast milk. And so if she takes a dose, maybe the next breastfeeding can be discarded through pump. But beyond that, it shouldn't have a major effect.
Agree.
So Stephen, while I have you on the line, I just want to take advantage and hopefully for our colleagues who are listening around the country and indeed around the world, with respect to patients who come in and for whatever reason they've had headaches, migraines that were not amenable to preventive therapy or rescue therapy by, let's say, beta blockers, calcium channel blockers, the so-called anti-epileptics or epileptics or membrane modulators. They went through some NSAIDs, et cetera, and now someone has placed them on opioids and they say, hey, the only thing that helps my headache is oxycodone or hydrocodone, and they're on 60, 75, 90 of those a month. What's your approach with those patients, both from a long-term strategy and during the first visit? How do you address the request for increased opioids? Because maybe the primary said, hey, I'm sending you to a headache specialist. I'm not giving any more hydrocodone or oxycodone. How do you approach that patient from visit one, both in terms of what you're doing that day and what are your long-term therapy goals?
I explained that opioids actually can make headaches worse. And if you take them long enough, they can actually destroy parts of the brain that are in brain control. Fortunately, for people using a lot of opioids, we have an inpatient unit where we do detoxification. And those patients are very difficult to detoxify as outpatients. And those are the type of patients we say, we think you should come in, we can get you off the medicines. And the odds of getting you better doing that are about 80% where you have control of your headache. So we would treat them with a preventative, maybe one of the new antibodies, maybe watch them and follow up, see if they start to improve spontaneously. But if we're taking a lot of opioids, we prefer to do it. We bring them in, we give them methadone. If they're taking a lot of butalbital, we give them phenobarbital. It's easy it can be done as an outpatient, but it requires lots of visits, lots of control. And over the years, we've actually gone for people who are taking lots of butalbital and lots of opioids, detoxification. And if they're willing to do that, we'll give them enough medication until they get admitted.
Okay. Another question that's come to me through colleagues is there any role for combination therapy with onabotulinum toxin as well as the monoclonal antibodies? Do you ever use those? Is there a synergistic effect, and have you found any evidence that works qualitatively or in the literature?
Well, that's my standard of care, because we had patients on botulinum toxin with partial response. And then when the antibodies came, since Botox lasted 3 months, we had a period of time where we could actually see them. And in some people, we had synergism. And what we're currently doing now is an evaluation to look at patients before and after adding an antibody to see what happens. And let's assume, for the sake of argument, they're on Botox, you start an antibody, they're doing much better. One of the things we might do is say, let's wait 4 months or 5 months for the Botox, see if it wears off and you get worse. And that's basically the way we're doing it, and it's my bias, they clearly are synergistic. Why? There are two different types of pain fibers.
Yep.
Little C's or little ones. A delta is a little bit bigger. Botox works on C fibers.
Right.
The antibodies work on the A delta fibers. So you're getting both a mechanistic and a clinically based synergism between the two. And some insurance companies are now paying for both.
Right, right. To summarize, then, the botulinum toxin is thought to work on smaller A fibers, C fibers, small C fibers, and the Gepants would then be working on, or monoclonal antibodies would be working on the larger.
Correct.
Okay.
Correct.
Another question that comes up frequently is the idea of, we mentioned with our postpartum case, hormonal perturbations. And so if people have, for instance, premenstrual dysphoric syndrome, or they have menometrorrhagia, they have other gynecologic signs or psychiatric signs of difficulty with the catamenial distribution of symptoms, and you notice that their migraines are worse, then is there a role for hormonal therapy in reducing migraines, maybe oral contraceptive therapy, or even steroidal therapies such as depo-medrol therapy, in terms of reducing migraine symptoms?
Absolutely. If a woman is on hormonal contraception, the first thing I recommend is that she not use placebo, take it continuously. And there's studies that clearly show that without that fall. If a woman is not on hormonal contraception, one trick is to give them an estrogen patch to be taken 3 or 4 days before the expected onset of her menses. That'll maintain plateau plasma levels of estrogen, and in many women that will work. So those are two good strategies to take naturally treated. Now, some of the women always say to me, well, isn't it not abnormal not to have periods if you take hormonal contraception all the time? And I say, no, it was abnormal to have periods. Cave women rarely had periods. They were pregnant all the time. So it's abnormal to have it. That's what I tell them.
Yeah, when we look back at the natural history of human beings with extended breastfeeding and frequent pregnancies, as you said, the number of periods that women have today is probably greater than at any time in human history. If you look back at the natural progression or anthropology of endocrinologic expression in women. Another question that I have, and hopefully some of our colleagues will benefit as well, is the idea of biofeedback. And you mentioned that, and I'm both in the psychiatric realm and in the chronic pain realm or migraine realm. I'm interested in how non-pharmacologic and pharmacologic therapies interact. And so certainly we have good evidence for biofeedback in tension headaches. What about in migraines? Have you found it to be effective? And is there a particular patient type for whom biofeedback might be effective?
There's good scientific evidence that biofeedback works in patients with migraine. I think the important issue is the type of patient. Some patients get scared of anything psychological, and you would do more harm than good. So I tried to explain to the patients, with these techniques, the body and the brain have its own pain control system, and you're tapping into that. And by tapping into the brain control pain system, you're taking advantage of your body's own natural way of controlling pain. It's not like we think you're crazy or you're nuts or this or that. We're just tapping into the way the body controls. I give the example of a soldier who wounded, comes in after the battle, has no pain because the pain control system said the only way you're going to get out of there alive is to have no pain. So we know it's there. We're learning more about it. In fact, very recently we found the location for it in the amygdala, just in Nature Science last week. And what's also interesting is a lot of people are now using ketamine for major depression, and it's actually found that's where ketamine works. So it's all starting to come together.
You mentioned military patients and how in a shock-like scenario or a high-stress scenario, patients who have horrific war wounds can actually turn off pain signals or dampen pain signals through the basal brain, the limbic system. There is a technique called battlefield acupuncture, or BFA. It's based off auriculotherapy, and they basically, in the military about 20 years ago, developed a way of using 5 points in the ear and basically small needles that are left in the ear to reduce opioid use on the battlefield, because there was concern that people might become confused, or if they were captured, this would lower their ability to access their training. And so they reduced opioid use by this technique. Have you found any of those acupuncture techniques to be helpful in folks with migraines or other types of headaches?
Well, some of the electronic devices we use are similar to that. Some of the devices, like TENS, have acupuncture-like and other types. And
right,
the concept
there's Altins or acupuncture-like TENS.
Yeah. So basically speaking, there's one device that works in the forehead, like a TENS unit. The new device by an Israeli company that actually works by turning on the pain control system. And so this is how some of the devices work, by actually feeding into that system. So you can do it through devices, you can do it through psychological techniques, a lot of ways of turning it on.
Now, while we're on this topic of integrated medicine, I know that cannabinoids have been all the rage in a lot of chronic pain syndromes around the country, and we have, and indeed around the world. We have lots of folks who are turning to THC-containing products, be that saleable marijuana with THC in it, or CBD products, or cannabidiol products, CBD. What are your thoughts about the use of THC or CBD in patients with migraines? And is there a role for that in your practice, or do you sort of advise patients against it?
Here's the fundamental problem. If you tell somebody to buy some grapes, one person will say, those were the most delicious things I ever tasted in my life. The other said, I wouldn't touch them, because there are tons and tons of varieties of grapes. Same with marijuana. Some of the older, recently, they're made high THC to low CBD versions. It turns out that maybe 2-to-1 is better, but just as important are the odors of terpenes. So in patients who are taking marijuana, the type of marijuana plant is crucial, and the odors are crucial, whether it's lemon or some other flavors. So until we have standardized formulations of the marijuana plant, we never know what the patient's getting. And some people have taken the pure THC and or pure CBD, and they have not gotten maximum results because they got the wrong grape. So I think the problem is that many of my patients have tried it. Some have got benefits, some have not. We never know what they're getting. But just as important, until we can actually get pure clones and test them, we won't know what best to give our patient. It's like having 10 different antibiotics, okay, made from a mold. You can't do that without knowing which one they're getting. That's the problem. Not that they work. It's not an ethical or moral issue. It's a scientific issue that we can't study them. And by the way, I did, oh God, almost 50 years ago, 45 years ago, the first study, the metabolism of THC in humans.
Fantastic. Well, as you know, and by virtue of being a researcher, you know, marijuana is still a class 1 drug in the United States, which means in order to study it, you've got to go through the NIDA, you've got to go through the FDA, the DEA, your state agency. And so there's basically 4 agencies you got to get around and get the paperwork across all the desks. It's very difficult. And what I found in the literature is that the doses of CBD that are studied are way higher than the doses of CBD that are commercially available or affordable. Whereas the doses of THC, as you alluded to, that are studied are usually quite low because there's one source, the University of Mississippi.
And it's a lousy source. And the problem is it's one strain.
Yeah.
So therefore, it's like saying the only antibiotic you can have is penicillin.
Correct.
You may have a bug that doesn't respond. So my objection is the fact that by limiting scientific studies, we don't know what's happening.
Yes, and the THC strains that are being grown today compared to Cheech and Chong marijuana is totally different. The THC content may be 3 to 4 times as high as what your grandfather's weed was. So
and it's quite clear that the right balance between THC and CBD is much more pleasant.
Okay, so I'm a new patient. I walk into your practice. I've been followed by my PCP, and then I got referred to secondary care by a general neurologist for headaches because the PCP was confused. And now the general neurologist scratches her head, and I'm on to Silverstein's clinic at Jefferson. And so what's your message when a patient walks through your door? Is it, you know, we're going to mitigate this role in your life, but you're always going to have headaches, or we can get you significantly better, or gee whiz, this is a tough problem. What's your general message to patients that walk through your door in a tertiary center?
I tell them about an 80% chance of giving them significant improvement. And all of my patients are just like you.
So Stephen, we've been at a very unusual time in our country with the advent of a 100-year pandemic, COVID-19, here in 2020. I know that that's affected my practice a lot. I'm doing a lot more telemedicine, but there are patients who have to come in for certain physical treatments, such as injection, et cetera. What have you seen in your practice in terms of the practicality of seeing patients? Is telehealth working for you okay in terms of the verbal interaction and seeing patients? And I'm using air quotes there in terms of seeing them. You're just seeing them videographically. And then finally, are there other effects that COVID might have on these patients besides access to care?
I think it's important to realize that there are patients who we've been following for years who come for a routine checkup every once in a while. For that, telehealth is good. And
Sure.
it'd be nice if they can get somewhere to check their signs if needed. But for a patient with problems or a patient who needs injections, it's not the same as being in the same room. So I would say that we still have emergency visits and we still have injection visits for Botox. The second important issue is people are worried that if they get the antibody, could COVID be worse? And I would say it's just the opposite, because it's some evidence that actually CGRP antibodies help the immune system. And in fact, there's a study now going on at Jefferson of giving people one of the small molecule CGRP antagonists to treat COVID.
Wow. All right. Fantastic. What role has CGRP given you in terms of giving patients hope? Is this a significant advance, or is this a Me Too issue where it's incremental change, or have you seen substantive changes with this class of therapy?
Because by definition, the only people who get CGRP are those who failed 2 or more drugs. And we didn't have it. So we had patients who failed lots of drugs, and we gave it to them and they got better. So basically speaking, using my sample of patients, it's different mechanism of action. We're getting people better in whom nothing else worked. There's still people who don't get better, but it's another arrow in our quiver, getting people better.
Fair to call it a game changer then?
It is a game changer.
Fantastic. Anything you wanted to get to, Stephen, that we didn't talk about, common questions or whatever?
Yeah, just a couple things. Migraine has been shamed. And for many years, people with migraine were thought to be mental problems or perfectionistic. You know, what do you think, what population of people in the world have more migraine than anybody else? Do you have any idea? Neurologists, 70%, one time we did a survey at the Academy of Neurology, 70%
Wow.
had migraine. And so first of all, it's nothing to be ashamed about. And because you can't see it and you see what it's doing to the person, doesn't mean they're faking it or using an excuse to get off from work. So I think it's a real disease. Finally, we're studying it and we're getting treatments that are actually seriously helping.
You know, in my world of primary care and psychiatry, we have an analogous phenomenon in the mental health arena with bipolar disorder, which has its own series of gifts and detractions. You know, it can limit life in terms of ability, but it also can be associated with creativity. And we're learning more about it in terms of how to treat people. And with new advances in therapy, have been able to help people unlock the positive sides of how their brain is constructed and sort of tamp down the negative sides of that. So I'm glad that you bring up the social stigma associated with any chronic phenomenon of pain that people can't see and put a label on that's easily understandable, because I think, unfortunately, many people do carry that stigma internally and externally, and it can negatively affect outcomes.
I should also mention the fact that there are disorders that are comorbid with migraine. What do I mean by that? They occur at a higher frequency, and that includes depression and bipolar disease. It doesn't mean that migraine is a symptom of depression or vice versa. If you have migraine, you may get you higher risk for depression later. If you have depression, you have a higher risk, and maybe there's a common genetic basis for both of them. So yeah, I think you need to
certainly in a general sense, we see that pain problems, sleep problems, and mood problems are about 60% comorbid, and it's bidirectional. So you can draw the arrow all around that triangle.
Exactly. And I think whatever field you're in, if you deal in any of those fields, you need to be able to figure out which are the other ones they have to get the patient better.
Absolutely. So colleagues, I want to thank you today for attending to this program, learning more and exploring more with us together about how new therapeutic advances can help to increase the quality of life by decreasing symptomatology, both in terms of frequency and intensity of migraine. And we wish each of you incredible success in treating your patients and bringing to them the best that science and humanity and medicine have to offer. Thank you.